Well, good morning, everyone, and an especially warm welcome to Professor John King, who has had a profound influence on my career and many others in this room. Very warm welcome to you, John. Lovely to see you. It gives me great pleasure to chair the initial symposium, which will be in relation to the advances in tendon imaging and management. I'd like to introduce the speakers, who will come in sequence, and then we'll leave questions to the end. First of all, we have Professor Hazel Screen. Welcome, Hazel, who is a biomedical engineer based here at Queen Mary Hospital. And her main interest is in tissue mechanics, and she's going to talk to us about advances in tendon imaging and the current state of play and future directions. Then we have Dr. Seth O'Neill. Welcome, Seth, who's going to talk to us about the use of imaging to guide diagnosis and treatment. Might I suggest another thesis for you, the decline of Leicester City and the removal of the Tinkerman.
I'm a Forest fan, so very close.
And then finally we have Igor, welcome, from Barcelona, a very experienced sports physiotherapist who's going to talk to us about his PhD research in relation to data collected on the Achilles tendon and long-distance runners. So welcome to all of you. First of all, if I could ask Hazel to come to the podium, please. Thank you.
Thank you. Right, well, thanks ever so much for the welcome, and it's lovely to be here with you all today. I think this is the best slide I've ever written for a talk. I have never started with a disclaimer, but, you know, today's the day. I am not actually a medical imager. I'm not a medical physicist by training. It's not really my area of expertise. If you were to ask what I did, and if you were to look on my website, this is the kind of thing you would see. So I'm a biomedical engineer by training, thank you, as you said. My interests, I'd say, are around tissue mechanics and mechanobiology. So you'd see these sorts of pictures of cells, this one, you go the cells on nearly all tendons, we're okay there. Bits of tendon material here at different nano, micro, macro kind of structural levels. And for those of you that kind of don't really know a huge amount about that field, if I just give you a little bit of a feel for what it is to get us started. So tissue mechanics, the concept there is to really ask something about our tissues at those nano and micro levels. How is the tissue structured? How is it organised? So what's its architecture? And how does that give it the mechanical properties that we see in that piece of tissue? And the other side, that mechanobiology side, looks at how that influences the cells within the tissue and how that controls turnover. So we know that our tissues, the cells in our tissues, perceive mechanical stimuli, they respond to that, and it's in response to that that we have chronic tissue homeostasis, so that tissue maintains health, or we perhaps see degenerative processes or repair processes. So I'm very interested in that global relationship. For example, what happens with aging? Do we see changes in the matrix? Do they affect the mechanics of the tissue? How might that influence how the tissue deforms? What the cells see? Can we understand the processes that are involved in getting us to injury and why injury is more prevalent in that age group? Okay, so that's what I'm kind of like talking about, and I could talk about for hours. But today it's medical imaging, so what am I doing here? Why am I wanting to talk about medical imaging in relation to tissue mechanics research? And actually in the last year or so, I've become extremely interested in this relationship, quite specifically in ultrasound as an imaging modality. And I'd kind of like to take you through a story and try to take you through so you understand why it is that we've gained this particular interest in ultrasound, where we're going with that research and what we're hoping to be able to achieve. Okay, so these pictures, you should know these much better than myself. I had to go online and try and find some clinical images. I'm sorry if they're not very good, but I found some clinical images of an Achilles tendon in various states of disrepair. So this is what you're used to seeing, I guess. What's the point in ultrasound imaging? We're there to try and visualise pathology. We want to maybe monitor injury, or perhaps more specifically, monitor rehabilitation, we hope, from injury, and use imaging as a modality to do that. So you might look at, I don't know, thickness, organisation, vascularisation. But effectively, you're looking at different markers of that tissue health, aren't you, and using imaging to monitor them in situ. Over time, there's been another body of work with ultrasound saying, can we look at mechanical properties of tissue in vivo? as well, using ultrasound. And that's quite a different use. So we're not just saying, can we look at that tissue, but we're saying, can we use it functionally as ultrasound to investigate how the tendon's stretching? We've been doing this for quite a few years. So these are probably the two real seminal papers in the field. Gosh, it's over 20 years ago now. That's absolutely terrifying. But here we go. Fukushiro and Fukunaga published these two papers, 95 and 96. The first really starting to look at how we could use ultrasonography to measure mechanical properties of tendon in situ. And this is still a very relevant and ongoing research field. This is a picture from a review paper. This is a bit small, isn't it? Journal of Applied Physiology 2015. Just to show you, these are some of the real big names in the field now at the moment working in this area, still trying to develop, improve the use of ultrasound imaging to investigate the mechanics of a tendon in vivo. There's still some way to go. And this is a picture from their study. It's rather nice as an overview of how the technique works. But I thought what I might actually do to try and take you through that was to move on to tell you about this lady's work. So she probably looks familiar to a number of you. Certainly Nick mentioned Sarah at the start there. So Sarah, I'm sure, has worked with a number of you on your projects over the years. Sarah did her PhD with Dylan and myself looking at in vivo mechanics of the Achilles tendon. She was doing eccentric and concentric loading and looking at that mechanics. And I thought I'd use her data and some of her images to explain a little bit about that, how that works. But here, I'm sure I'll be in trouble for this photo, but this is a lovely photo of her. This is Professor Savio Wu, who is one of the huge players in tendon research. And there she is with him receiving an award for her PhD work, a highly prestigious research award for it. So that was a really exciting time. Okay, so thank you, Sarah. I've stolen some pictures, but let's use them to talk through how this works. So, if we want to measure mechanical properties of a tissue, we want to look at the relationship between the force and the extension, don't we? So we apply a force and we see how much that tissue stretches, so we can draw a graph to relate them. So we're going to need to get measures of tendon force and tendon extension in this particular setup. So what do we tend to do? Well, to get tendon force, we need to try and get effectively a measure here from the tendon. Well, we can use traditionally a force plate here to get the force actually through the foot. If we put enough motion markers, obviously we've used CODA in these labs here, we can get a torque measure, a moment arm around the ankle to get an estimate of the force that's going through the tendon during loading. Okay, that gives us a force estimate. How about tendon extension? Well, this is where the ultrasound comes in. One on the end of the tendon, that's not too big a problem. We can put a marker on the calcaneus, we can see that end. If we want to track where the other end of this tendon is, this is where we need the ultrasound, so we can view how that's moving when you're stretching and loading the tissue. So I've got a little picture here. This is actually the setup of one of her patients, so we can see everything. There we go, there's our force plate. There's our CODA motion markers to get the torque. Here's our marker on the calcaneus, and there we can see the ultrasound probe scanning where the myotendinous junction is, so we can track that in space to look at how the tendon's stretching. And because you can see them there as well, to know, obviously you can take a number of other measures, which was can in the lab. Looking at things like EMG is, of course, very useful at the same time, so you can look at how much those muscles are working during the exercise. Okay. But one of the big problems with this technique was, there's a few that we're trying to iron out, but one of them, as you can imagine, is trying to track that myotendinous junction with the ultrasounds, and Cyrus spent a lot of time in this particular area trying to develop and optimize this technique. We're looking at something that's moving a long way, it's changing shape as it moves. How do you try and track that over a video? You really do not want to spend your life, and boy, this would be a bad PhD, looking from picture to picture to picture to picture and trying to track the movement of that little space over thousands of frames. So how can you try and develop ways to automate and look at that during movement? She spent a lot of time, looking at videos here. These are sort of pictures from the start and the end of the movement, trying to track that myotendinous junction in situ. But these are some of the issues that you get with these techniques, that are the ongoing problems that review paper talks about. How do you get an accurate measure of extension from that particular marker? Of course, you must account for movement of the probe. If you rotate that probe, you're going to get an artificial measure of the length change in the tendon, so you have to be very careful to account for that. And as I said at the start, of course, that force measures an estimate of torque. How do we optimise and get that as good as possible? This is very much an ongoing field of trying to improve this method of measuring and trying to characterise forces through the tendon in vivo. Okay. And here's some of Sarah's data, just so you can see what you get out, and it's quite an interesting story, just to show you some of the key findings that she got from her thesis. Of course, you'll get out graphs of movement time, so during the exercise, and we've got eccentric exercise, and then going up in a concentric exercise. You can look at force against time, you can look at the length of the tendon against time. That's the two parameters you'll pull out, and then, of course, you can plot them one against the other. And these are sort of some of her key findings. Unsurprisingly, EMG was higher during eccentric loading. You'd always expect it to be. But we saw very much exactly the same force length curves in the tendon, which we were marginally depressed about at the time. We thought we might see something exciting. Maybe there's something interesting here in the difference in the sort of temporal characteristics and how fast that loading period is. But what we did find that was really interesting was that if we looked at the vibrations in the tendon, we saw some really big differences. And effectively here, you could look at either the force plate data or you could look at the EMG data. We're not looking at the actual numbers, the magnitude of the response, but we're looking at the frequencies involved and what you see in that tissue. And this is looking at the force plate, and it's saying, here's all the different frequencies in the signal, and here's effectively how much of them there are. And you'll see, low frequencies here, there's a lot of those. Well, the person's moving slowly, of course there is. You'll see those frequencies in their movement. But this bit here is what we found rather interesting. If we look at around the 10 hertz mark, here's concentric, here's eccentric loading. Look at that huge increase in vibration or sort of motion in that tendon at around the 10 hertz level. So it seems to be that there's this kind of large vibration, physiological tremor, perhaps, in the Achilles tendon during eccentric loading. And that's led us off into a whole pile of other studies at the moment, which we're steadily working our way through, with the concept that maybe that high-frequency loading is important in some way. If we know that if you do an eccentric load, your Achilles tendinopathy gets better, hopefully. Certainly you've got a better chance than if you do a concentric loading protocol. Is there anything in that vibration that may explain that? And we've been doing some cell studies, and I've been going back to my home turf where I'm happy with tissues and cells and exploring that hypothesis a little bit. But back to the matter in hand. So that's a little bit of an introduction to what tissue mechanics is, a bit of background to what we've done so far with ultrasound to date. Okay, so how are we going forward from here, and what's the latest things? Well, I need to take you through some of our tissue mechanics data to show you what we found and why I'm interested and why we wanted to start to look for it in vivo. So here we go, tissue mechanics. If you asked me to tell you what a tendon looked like, that's what I would draw you. Probably a bit different to the average clinical image, but that's how I think of tendon. I'm very interested in this structure as a hierarchy. This is nanoscale, 300 nanometer collagen molecules, building up to make fibrils, fibres, fascicles. We have cross-links down here holding that collagen together. If you go through all of these structural levels here, we have a proteoglycan-rich matrix surrounding that tissue, holding it together. The crimp in the tissue here at the fibril level, all of the cells sitting along that crimp waveform. That's what I see. That's what I'm interested in with tendon. And effectively a large amount of my work's been about developing equipment, I know rigs, designing experiments, coming up with ways that I can take a piece of tissue, keep it still alive, put it into a rig so I can stretch it and I can view it in some way whilst it's being stretched. So put it on a microscope maybe, you get cameras on it so you can get a kind of macro view of response. We've done this at a nanoscale with X-ray synchrotron beams, different ways of looking at what's happening within that tissue when it's being stretched. Okay. And I started a body of work, 6-7 years ago now, with an interest really in energy storing tendons and saying, so our Achilles here, an energy storing tendon, we know that they seem to cope very well with high strains and they're very efficient in energy storage. Is there something special about them that allows them to do that effectively? And I started the study actually in the horse. So this is a equivalent to the horse Achilles tendon. It's the SDFT, superficial digital flexor tendon. Really highly loaded. Horses run faster than us. So we can see really very large energy storage in that particular tendon. So can I look at this tendon, compare it with the positional tendon here, and see if we can see structural, mechanical differences between the two to understand how that energy storing tendon is specialised. And we did that in the horse. We've done it more recently in the human as well. I'm going to primarily show you the horse data just because it's more organised at the moment and we still haven't published on the human, but we're seeing a very similar story in the two. Okay. So as I was describing, a few different techniques to look at it. We'll take the whole tendon. Here you go. This is where I put a whole tendon in a rig, pattern it so I can look at the local strains, see how it deforms under loading. I want to look at the composition potentially, what's in there, do some histology to look at how it's organised to try and understand that. We might then take the fascicles out. Oops, let's go back. Here we go, there's a fascicle in here. Take those out, do mechanics directly at that level of the structure, look again at composition, histology, proteomics, those different things that let us see what's in there. And then going down the level again, here's where I potentially put that onto a rig that sits on a microscope. And this is a confocal microscopy image of the cells in a living piece of tendon. And then we can stretch it and we can see how they deform and we can start to get mechanics at these further down levels here, down at the fibrils and so on. So we kind of went through this kind of study and to look at the response. And if we just start with the whole tendon properties so we can actually see what those differences are, we see these very distinct mechanical properties in energy storing tendons relative to positional tendon. So let's see, here we go. Stress strain curve for a piece of tendon. This is an energy store, this is a positional tendon. So that energy storage tendon is more extensible, it's less stiff overall, so it's able to stretch more to store energy and recoil. If you take that piece of tissue and you cycle it, and you keep cycling it until it fails, you can draw a curve here. This is a creep curve, so you take it to the same force and you keep taking it and it slowly stretches until it breaks. And if you look at the number of cycles it takes to break, here's our energy stores, way back over here are our positional tendons, far more cycles to failure, so we've got a far more fatigue resistant piece of tissue in an energy storing tendon. So very clear, distinct mechanical differences in these two bits of tissue. And Siobhan Thorpe came to work with me for about 6 years as a postdoc, starting to ask the questions about why that is. Can we look structurally at how we get that increased fatigue resistance? And there's been lots of things, but this is the one that I want to concentrate on, because will take us to the story of imaging. We're getting there. This is some of the first data she collected. And these are stress strain curves again. This is energy storing SBFT, whole tendon. This is a fascicle. This is a positional tendon, and this is a fascicle from the tendon. And there's lots of interesting things in it, but again, for the interest of time, I want to focus on one. Let's look at that positional tendon to start with, and let's look at the failure strain. Pretty similar, the same sort of properties there for the whole tendon, for fascicle, they fail at roughly the same strain. This one confused me somewhat more. That's a whole tendon, failure strain way up here at 22. This is a single fascicle, failed just over 10% strain. There's a massive difference from a single fascicle from that tissue, from the whole tissue. And now this is an equine tendon, remember, and this bothered me even more because using ultrasound and putting horses on treadmills, why anyone thinks that's a good experiment is beyond me. It sounds life-threatening, but people have done this and tried to look and characterise what the mechanical properties are in a tendon, in a horse, whilst it's galloping. It's loaded to somewhere around here, which seems to be beyond the failure properties of an individual fascicle. So how is this possible? Because everyone's talked about the fascicles, they say that's your collagen, that's what's loaded, that's what you see in the tissue. How is it that we can get a whole tendon to stretch almost twice as much as the fascicles within it? So we asked questions about what's between them, what's there that would potentially allow this behaviour and all this extra extension in the tissue. So here's what's between them, the interfascicular matrix, for want of a better term. And you can see it here. This is histology, so this is a fascicle. Here's the interfascicular matrix between them. Here's the cells in it. Here's a fascicle. So you can see this region of tissue that's really quite different between the fascicles in a tendon. And being an engineer, the first thing I wanted to do with it is look at its mechanical properties and see if we could understand something about it. So we developed a test and set up to do it. Take two fascicles, like you can see here. We cut the ends off opposing ones, so we've just got this nice length of matrix in the middle, so we can pull that in shear to failure and have a look at its mechanical properties. And the first thing about these, I was stunned by how much force it takes. I know 1 Newton doesn't sound terribly exciting, or 1.5 newtons, but a fascicle fails at 2 newtons. These are small bits of material. This is a really short piece of material as well, so that's quite impressive. That's quite a lot of force. So once I got over being quite excited by how much force it could take, I felt very depressed because they seemed to be exactly the same up here at failure, and that didn't seem very interesting. But then I thought about it again, said, well, they don't go to here, do they, if the tendon's working? If the tendon's stretching and the whole thing isn't falling apart, it's going to be working somewhere around here. And they look rather different somewhere around here. If you look at this region, this is your energy store, this is your positional tendon. So you get more extensibility effectively, you need less force to allow the IFM in an energy storing tendon to stretch. Okay. Alright, so that's kind of intriguing. You can do that across all of them. I've just shown you one example curve. You should make me prove that by showing you the rest of the data. Here it is. So we can do that. This graph is saying for different percentages of the failure load, how much extension do you get? So if you look at sort of 10% of the failure force here, how much extension do you get? So you get more in the energy store than the positional tendon. Here it's really consistent, more in the energy store than the positional, right the way up to failure where they come together again. So we can see we have more stretchability or more ability to slide in that matrix. That's well and good, but remember we're talking about fatigue resistance in that tissue as well. So I said the next question, what happens if you cyclically load it? That's what we're looking for. Can it stretch and can it recover? And these curves, I thought these were beautiful. So this is a load, unload curve for just that little tiny bit of IFM to see how it responds to loading. That's the energy store, that is the positional tendon. And see how these spread out? This is because you're taking it to the same load, but it's sort of getting longer and longer because it's recovering less and less effectively with every cycle as it pulls apart. And actually, just as I showed you before, you can look at the cycles then till failure, and you saw hugely more cycles before failure in the energy store than in the positional tendon. So it seems that that interfascicular matrix allows sliding more easily and also allows better recoil and is more elastic in nature. Okay, so that was really rather interesting and implies if you have an energy storing tendon, for it to work effectively and to stretch, it needs to do that by the fascicles sliding and recoiling, managed by the properties of that interfascicular matrix. And the reason I got particularly interested in that is because another part of the story and what we were looking at was, can we see changes with age? Because if we can see changes, they might explain why we're more injury prone. Would it make sense? And this is what really got exciting. If we looked at the interfascicular matrix properties with age, the fascicles didn't change at all, by the way. If you look with age and you looked at the collagen of the tendon, didn't change. Mechanics was identical. But the interfascicular matrix changed a lot. This was that graph I showed you earlier, and this was the bit that got me all excited. And there it is in an old horse. So it's gone. So you've lost that low stiffness region in the tissue in an old horse. That's all the data again together. So this age against that degree of extension, and down it goes until it reaches the positional tendon. If you looked at that fatigue resistance, I did the same thing, those cycles. Here was our cycles to failure in our young energy store, and down it went with age to match the positional tendon. So we see a loss in those properties of the energy storing tendon that we thought was so exciting and potentially allowed it to work so effectively. So we hypothesised at this stage that having an energy storing tendon with an IFM that's elastic and it's extensible is really important for function. So it can allow, when the tendon stretches, it allows the fascicles to slide and it allows them to recoil back effectively. And if you start to lose that with age and that IFM doesn't allow that behaviour, potentially you've got more of a risk of injury because it's stiff, it will get damaged and you'll propagate down to an injury risk. Okay, so we've done lots of different bits of work. Just a couple of slides to show you what we're thinking about, what's in the IFM. That's the next question and my tissue mechanics brain would want to know about. Lots of elastin. Elastin's black. Oh, there was lots of it. All very localised to the IFM. Lots of lubricin. That's a nice one. Cartilage is the main one you recognise with lubricin because the giveaway is the name. It's a lubricator. So it's a proteoglycan that lubricates. Lots of it in the IFM. Everything you want for easy sliding and good recoil. Okay. This is an immunostain. It's another stain to look at elastin in red here, all localised to the IFM. We quantified it a bit more fully in this bit of work and found that the amount reduces with age. This is the energy store, the positional, here's the old, so it reduces with age, so you have less elastin as well, so you see the matrix changes that are contributing to these differences. And it also fragmented, and that's one of the problems you see in archeries and things with age. Collagen, elastin will fragment and reduce the ability of that tissue to elastically stretch and recoil. And sorry, I should have updated this. This paper's just come out, so well done to Marta. That's come out in Scientific Reports just now. Okay. So we know the IFM is elastin-rich, it's proteoglycan-rich, it's also rather cell-rich. And that's just a simple histology slide. All those cells there in the intervesicular matrix region, rather rounded. And we did a load of other proteomic studies. I think these are great. No idea what they mean. They're beautiful. But my proteomics colleague shows me them and says things about them. No, I do know what they mean. They're a map that shows all of the different proteins that are in the tissue, and it groups them together and looks at how they're related. And you can see up here, you can see lots of collagens, lots of cell proteins, because it's a very cellular region. What you also see is what's called neopeptides, and that's newly formed bits of matrix. So it's showing that you're making new matrix, all in the intervesicular matrix. This is a different technique for looking at turnover of the matrix, or making new matrix. C12C is a marker of making new collagen. There it is, beautifully localized to the intervesicular matrix. Here it is shown alongside MMP1, and MMP1 is something that breaks down the matrix. So you're seeing effectively breakdown and manufacture of new matrix, all localized to the intervesicular matrix. So it doesn't really seem to do a lot through the rest of the tissue. The collagen kind of sits there and it's okay. But if you look at actually how the tissue is responding, we see that you've got a very active, rapidly turned over intervesicular matrix, whereas the rest of the tissue is reasonably dormant. So that IFM story became really very interesting to us, and we're pursuing various bits of work to look at those cells and understand a bit more about maybe we could work on therapies that manipulate that particular cell population, understand its phenotype in more detail. So that's one area. But back to today, what about imaging? So we're there, okay. This is why I started to get interested in medical imaging, because I could see potentially some diagnostic opportunities here. We've established, we think, that the intervesicular matrix is extremely important for tendon health. If we want a tendon to work effectively and healthily, we need the fascicles to slide and we need them to recoil. We talked about imaging earlier, and we talked about the fact that if you're doing imaging, you're looking for markers of tissue health that you can monitor and assess in vivo to look at how that tissue is responding. Is there any way we can put this together and use imaging to actually measure intervesicular matrix sliding as a sort of diagnostic measure? And that's where we're trying to go now and what we're trying to do, and we've got some funding. So let's have a think about what we need to be able to do that effectively. Okay, well, we're going to need very high resolution, higher than we normally have in most ultrasound images that we look at the moment, because we're going to have to be able to distinguish at the fascicle size. And an individual fascicle is, what, 300 microns, possibly less? So that's real high resolution in those particular images. We're also going to have to be able to determine deformations and strains locally. So not just using the probe to look at how the tendon's stretching, but looking at a region of tissue and looking at how that region is deforming and stretching and how the individual fascicles are stretching. And of course, we need to distinguish slip, because we need to look at how one fascicle is going to move relative to another. So this is pushing the boundaries of where we're going with imaging. Of course, we have elastography, which I'm sure most of you have heard of or are familiar with. We can use ultrasound elastography in some manners around this. It's going to help us particularly here with the ability to determine deformations or strains locally in a different region of the tissue. And for those that haven't used it or don't know too much, with the elastography, effectively you take an ultrasound image of the tendon and you can do a couple of things. You can physically deform it, push it, and then take another image, and then you get the force from deforming it and you can see how much it's deformed. So you can get that force-deformation relationship that way. Perhaps what would be more useful for us would be shear wave elastography, where effectively you let a wave travel through the tissue, and the stiffer the tissue, the faster it travels. So you can use that measure of how fast it's travelling as a measure of the properties of the tissue. So that might give us some insights that are useful, but it doesn't really hit these other two here for us. And to hit those, we really need to foray into the world of medical physics in some detail and try and develop the techniques to see if we can push imaging boundaries to ask some different types of questions. Okay. So we've started this work in the Achilles tendon, and I think this is a really nice place to start, because here's our picture that we were talking about earlier. Here's our structure, but up here we've got a little extra level that you're probably all very familiar with. Here's our whole tendon. We know we've got multiple muscles attached to the Achilles tendon, the gastroc head, the soleus. So you've got effectively fibres coming into the Achilles tendon from each of those different muscle heads. So if you look at the structure, you have bundles of fascicles from the different muscle heads and an interbundle matrix. And we know that we want those muscles to operate independently and to load differently. So it strikes me that you're really going to have sliding movement between those tendon sections if we want that tendon to operate properly. Otherwise, how can you use your soleus without your gastroc? You need an interface that allows extension. So we're very interested in taking this hypothesis into this particular field. Can we see stiffening changes with age in that matrix? Is it that you stop allowing the soleus muscle to work and move that bit of Achilles relative to the gastroc? Is that a problem that initiates or starts injury? So that's what we're trying to look at the moment. And we've brought a few people in, and I'll introduce slowly. But the first person to tell you about is Laura Slane down here. And Laura was looking at this, and we met at a conference a few years ago to talk about it, because she actually did her PhD starting to look at in vivo ultrasound, local measures in tendon. And here's what she did. She'd effectively take an ultrasound image of the Achilles during, calf raises, walking, isometric exercise. She did all sorts of things. She'd get frames like this as a video, and she'd set up and she developed some MATLAB coding so she could track the speckle pattern over time to see how that tendon deforms. And there's a data's there, but it's a bit small. Here we go. There's a big version. This is a kind of strain map of how that tissue deformed and what she found. So here in blue is where we start, we move, here's where we end. So here's the deep portion relative to the superficial portion of the Achilles tendon. It doesn't strain uniformly. So that was very exciting. If you actually then start to look at people of different ages, so she looked at a young group and she looked at a middle-aged group. Here's our young, here is our deep and our superficial. There's a difference between the two regions. Here's our middle-aged. There's still a difference, but it's reducing, it's significantly smaller. So she was starting to see less ability for sliding, potentially, in that intervesicular matrix as people were getting older. So we're very excited by this, and we've been talking and we're working with Laura, because if we really want, and sorry, that's her paper, if you want to have a look at it, that's the title that was published in 2015. So we're looking with Laura now and saying, can we start to get some more detail? Because while this is interesting, it doesn't give us the resolution we need. We can see a global variation in strain across the tendon, but we want to have the ability to distinguish right down at that fascicle level and to really see where the slip plane is and to measure the extent of that and to understand what's happening in the tissue. So how do we do it? Well, let's think about what we need. Resolution to start with. We know we can up the frequency. If we up the frequency of ultrasound, we improve the resolution capacity. Okay, that's great. Not too difficult to get resolution in that plane. So you have not too many problems with depth. Unfortunately, if you want to get lateral resolution, you need a very small probe. So you bring all of the different piezoelectric crystals closer together. That gives you the resolution. We can't do that because we're trying to look at huge movements in a tissue. So if you have a tiny little probe like this, you can forget it. You're not going to see anything. So we need to find other ways of being able to improve resolution laterally as well. So we're looking at things like beam steering approaches as well, which is rather fun, medical physics, saying actually if you control, instead of having the ultrasound beam doing what you expect and just going straight through the tissue, if you steer it, you can use the better resolution of that beam that you get in the plane by turning it in the directions that you want it, so it's lateral as well. So we start to work on using beam steering approaches to give us an improved resolution in the tissue. The other big issue is distinguishing slip. And anyone who's ever tried to do any sort of image correlation techniques will know that this is a nightmare, trying to measure these parameters. You're trying to track the movement of speckle patterns using correlation techniques, but all of these work by sort of finding a small window and looking at what it does. It will deform a bit and it will move a bit. It doesn't mind that. It was designed for like bits of steel. They're very boring, very homogeneous. They just all stretch a bit. It works beautifully to look at strains in a tissue like that. It works quite well if the strains are non-uniform, but they're all going in the same direction. It completely falls apart when one bit goes one way and the other bit goes the other way. So trying to find mechanisms to look at that boundary are extremely difficult, and that's very much an image processing mathematical task that we're trying to put in hand at the moment. Okay, So that's kind of what we're trying to achieve, and this is the team we've got together to do it. So we've got Laura on board. We've also brought in Jeff Bamber, who is very much the ultrasound expert. So he works at the ICR. His background's really in cancer research, but in cancer, he looks at breast cancer. Diagnosing slip is really important for him, for how the tumour moves relative to the tissue. So he's very focused in that area and can bring all of his medical imaging advances to try and answer some of these musculoskeletal problems as well. So it's been fun for him to learn about the musculoskeletal world as we try to advance this. There you go, you'll recognise this one, Dylan, but we've also got Pete Clegg, because we need to, of course, make sure this is clinically relevant. We're working this with an effective fashion. Pete is an equine vet. Remember, we started with the horse. Horse Achilles problems or SDFT problems are a huge issue. So we're also interested in applications there. And Pete also worked with me over the years on a lot of this work on the tissue mechanics. So there's our kind of team working together. Tony started as a postdoc with us about 4 years ago on a grant, 4 months ago, sorry, on a grant by the Horse Race Betting Levy Board to start on that work, working towards horses. And we have some QM funding for PhD students starting as well, any time now, I hope, to see if we can start to develop technology to really start to ask some different questions about ultrasound. So moving into functional imaging, where you're looking not just at global strains or not just at pictures, but can we start to look functionally at how the tissue's moving? So I think that's where ultrasound's going for me. Okay, and on that note, I shall say thank you. Sorry, I'm a couple of minutes over, but thank you very much, and that's me done.
Thank you very much, Hazel, for a very interesting talk. I'd like to welcome Seth to the podium, please.
Right. Thank you very much, Simon, for the invitation to come and talk to you today. I'm going to be talking to you about, obviously, looking at the clinical application of some of these imaging techniques. But most importantly, what I'm going to try and do is actually cover what the papers actually don't tell you, because there's a lot of debate on social media, particularly if any of you are active on Twitter and the like, regarding medical imaging, and particularly ultrasound, and the fact that we find that a lot of asymptomatic individuals have high levels of pathology in their tissue potentially. And this creates a lot of debate with when and how we should be using these tools in a clinical environment. And I'm hoping to sort of settle that idea a little bit and read between the lines in the papers, because they often miss the important aspects and don't give you all of the important bits you need to take for your clinical work. So just to set the scene first of all, when we talk about tendinopathy, it's a bigger issue than most people realise, okay? So stats from a general population study in Holland show that the incidence rates are very high. The red data actually comes from a UK-based study and is a 40-year-old female study only, so we might be wrong with the incidence rates for that particular disorder, the tib-post tendons. But what we can be quite confident with is that lower limb tendinopathy is actually more prevalent than osteoarthritis in the lower limb, according to robust, large-scale data. Now, that's not something you're taught at medical school, or certainly at physio school. We're taught that OA is our sort of typical thing that we'll see much more of. It's a big problem, and we need to be looking at answering the question of how we deal with tendinopathy using larger scale research in more robust manners, using multidisciplinary sort of teams. Obviously, what you guys are doing here looks like it's going to be quite exciting, and will lead into a little bit of what we're talking about now as well. But as part of understanding how we would image for tendinopathy, we need to understand what tendinopathy is in the first instance. Now, I'm not going to give you a masterclass in that. We're just going to literally give you the basics. Most of us now are happy that it's largely a degenerative condition with some inflammatory aspects. So there's certain cascade chemicals that are involved that we would term, if we're purely from a sort of lab background, are inflammatory. From a clinical perspective, they're not the prostaglandin-driven inflammation that you learn about at medical school and understand often as inflammation. So a little bit different, and that's what creates some of the some of the debate that occurs in social media at the moment. In terms of risk factors can be thought of as influencing the two components that lead to alterations in tissue, either the repair rate on the tissue or the wear rate on the tissue. And that's something that we've sort of published work on and sort of have a decent sort of understanding of. But we don't know how big a factor each of these things are for tendinopathy. Okay. Now, we know on normal ultrasound imaging we'll see changes in the structure of something like the Achilles in this instance. The calcaneum's just here, so this is a healthy tendon at the top and a tendon with mid-portion tendinopathy, as we term it, below. We can all see that, and most of you, I'm sure, have probably actually used these tools to look at tendinopathic tendons in the clinic. Now, what we have to ask ourselves about that is, okay, that's the structure that's changed. Well, what changes in the structure? And Hazel's just gone through that already and highlighted the key aspects that change in structure. Okay, so the intrafascicular matrix will alter the cell population. We have information on that. It will alter some of the aligned structure of the tendons potentially. And we get a definite alteration in ground substance, and a variety of chemicals that sit within the ground substance has been shown. And the debate is that once you've got this breakdown in the collagen structure, you can then get near vessels and nerve tissue ingrown into the tendon. So those aspects are maybe where we want to be looking at or looking for when we do some of our imaging techniques. And that's largely where imaging is centred. But we have to ask ourselves, well, can imaging really identify those aspects? Now, apparently so. Structure of the tendon, or disorganisation of the tendon, particularly when it comes to lower limb, patella and Achilles, is the largest known risk factor for developing tendinopathy, particularly when we look at elite sports and people going through that elite sporting environment where we can control many of the other aspects that might influence tendon health. But we also know from quite robust data, systematic review down here in BJSM a few years ago by Benjamin Drew, that suggests that structure does not correspond to clinical outcome, pain level or functional levels in lower limb tendons. Now, this is a debate because there are problems with that paper, and many people use that paper to say we shouldn't be using imaging because it doesn't inform our interactions with our patients. Now, I'd put a little warning on that and get you to think about what that paper actually looked at and what forms of imaging were utilised in that, because there's been a big change in the types of imaging that are available for tendon research and tendon clinical practice since then, and they weren't included in that study. Okay? So the main thing in that study is it looked at bog standard MRI and bog standard B-mode ultrasound, grayscale. Okay? It didn't use any of the novel stuff because there weren't papers that were published at the time to include in the systematic review. Bar one paper that looked at UTC imaging, which we'll talk about in a little bit, but one paper doesn't make a robust evidence base, and there's problems with the paper that was included as well. It's a robust study, lovely study by a very good group in Holland, but the clinical shift in their outcome was quite minimal, suggesting actually they didn't get a good clinical change. Therefore, why would you ever expect a change in the tendon structure? That would be part of my discussion. I'm lower limb based, I'm not upper limb based, but when we come to upper limb tendons, they're far more complex. Okay? The Achilles is lovely, which is my research field. It's two muscles. We can have two heads of gastroc, so we can call it three if we want, and triceps psoas, and it actually forms into one common tendon. Now we get up to the rotator cuff, and we can see a much more complex issue there. We have the cable and the crescent, and they're things that often, again, we aren't taught about. But if you get a tear in this section compared to this section, or a tear that goes through the actual cable itself, the symptoms that you would expect to get are quite different. And they're normally not accounted for in the clinical studies, the outcome studies where they look at using interventions. And that is a massive flaw in those papers, unfortunately, with the conclusions we can then make based on that. But unfortunately, a lot of people don't realise about this part of the anatomy and never challenge those papers regarding it. So, B-mode ultrasound, the problems with it. How do we quantify that? If I want to say, this tendon is what it looks like now at day one, I'm going to do my 12 weeks of rehabilitation and I'm going to remeasure your tendon to see if it's improved, how the hell do I do that? I can measure the AP diameter, but then papers differ. Some will measure it a certain height up from the calcaneum. That's no good if the swelling's above that. Equally, you need to make sure you measure the exact same zone next time you measure it. And that's not normally well done because you only measure it in this angle, this view. Well, how do you make sure you're exactly the same distance from the calcaneum as you were previously? See the problems? How do we determine how hypoechoic that area is or how hyperechoic that area is? Major problems. We can't do it. There's no quantifiable method that exists at this moment in time that is robust. There's scales that are often 0 to 4, but they're not robust. And that's a bit of a problem when we look at outcome data. And that's what we're talking about at the moment. For clinical identification and diagnosis, wonderful. Okay? Because we tend not to see this Well, what we don't see in a patient with Achilles tendinopathy is we don't see that. I describe it as rocking horse poo. It doesn't exist. You don't get a patient, generally speaking, they are the one that you remember because they stand out. They're the 1 in 300 patient. Comes through the door, they've got all the hallmarks of Achilles tendinopathy, but when you actually examine them, they have no alteration in their tendon structure. They are exceptionally rare. But if we looked at a healthy population and took the whole of the borough here, we'd find some people that had dodgy looking tendons and no pain. But what do? Do they do enough with it to actually ever trigger a response in the tendon? That's often what's not looked at in the studies. We do these sort of non-symptomatic studies, but we don't look at their function. So if you sit down all day and you've got a dodgy tendon, it's probably not going to hurt you. If you've got a dodgy tendon and I stick you through military training or make you go and play elite football, it's probably going to get sore. I don't know of any data that shows you it doesn't, and certainly that's what we see in our clinical environment. So that's part of the problem with some of this data, and that's what we have to challenge about. We also know from the background, and I've got the same slide that you've actually lifted off Google as well, so Google's always good for images. So it's an Oberg's study, this comes from I think quite a while back, on vascularization, so colour Doppler of how much blood vessels there are within the tendon. We can quantify it in a way of saying, well, it goes either into a quarter, half, 3/4 or all the way through the tendon, and we can try and work out how many vessels there are in the tendon. But again, massively different, because none of the studies standardise across all the studies how they actually control this in the first instance. So if I've got you all up here now and tested you for Doppler in your Achilles, some of you have had blood flow, some of you wouldn't. Some of you have been fidgeting, some of you haven't. If I made you all do 400-metre walk first and standardised it, we get a bit more robust data, but that's not done in the papers. So when we then conclude that actually there is no relationship between neovascularity and tendon pain and tendon recovery, we have to be aware of that limitation in those studies, and in particular this study, which is a big, robust study. Okay. So we should be careful maybe about throwing out the baby with the bathwater at this instance and saying that imaging is useless because it's not been done very well. The studies need to be redone and actually cover the methodological weaknesses that they have. So alarm bells should be ringing for us all when we talk about imaging and its use down the line. So, my other big thing, why the hell would we ever expect imaging to correlate to pain? You get a ruptured Achilles tendon is my example I'd give you. I scan you on day one, you've just ruptured it, you've walked into A&E where I used to work, we scan you. You're going to have quite a substantial amount of pain and a knackered looking tendon. Structure and pain and function would be quite correlated, yeah? Would all be happy with that? Now, if I look at you 3 months later because you didn't come to A&E, you didn't ever seek care, you walked around in a funny gait pattern and it never healed, I scan you, your tendon looks knackered, but you don't have pain. It's healed over. Well, the two don't correlate. So what problem do we have when we scan tendinopathic tendons? We're scanning them after they've had their symptoms for a while. Well, when would the pain ever have correlated? It might have correlated at the early outset. It probably won't correlate later down the line because the chemical reaction in the tissue and the structural response will be very different. Or maybe I actually need to make you all do the same amount of running or walking prior to quantifying your pain to ensure that I've got a decent measure. Because when they come into research studies, you don't know how active they've been outdoors first, in the first instance. And that's the same in the clinic. When you fill out a Visa A, which is one of our PROMs, our patient-reported outcome measures for the Achilles, we don't know what they did the day before. So if they've run the last night, their PROM, they score very sort of low on it. They're quite disabled and quite symptomatic. If they didn't run the day before, didn't walk the day before, they don't have symptoms particularly severely on that day. That's not controlled for in the research. When people try and correlate these things up, it's a major methodological weakness of the studies. Okay. Now, if we go into what it can tell us, we can, with ultrasound particularly, identify all of these subcategories of Achilles tendinopathy. Has anyone ever seen a study that's actually done that? Because they don't. They take, oh, you've got Achilles tendinopathy, you get eccentrics and do this. Okay, well if you've got longitudinal tear, partial rupture, this is what Dylan's group's sort of identified with Otto down here, partial ruptures, some of these other splits, the fascia crura info, well, they're not going to respond the same, are they? I suspect not, but we don't know. We don't have evidence, but surely they won't respond in the same way as a pure tendinopathic degenerative tendon would do. The ability of the tissue to actually remodel and the mechanics of the tendon to change is not going to be the same across all of those disorders. Studies need to do better, and they need to split out these aspects. It's quite critical when we go forwards and start to look in more information. I think the same could be true of insertional, and actually we should identify whether the response is more in the bone, the bursa, or the tendon. And that's also another aspect. They're all the same clinical entity. They're all caused by compression of the calcaneum into the tendon, but which tissue responded and where their symptom drivers from is different. And therefore, probably where the treatment needs to be directed is also different. Certainly, if we look at some of the shockwave therapy or any pharmaceutical intervention, they will be very different because those tissues will all respond different to that. For loading, might not be the same way. Okay. Now, with us at Leicester at the moment, we're interested in UTC, and it's one of the new types of imaging. And we're going to sort of look at what some of these new imaging methods can actually tell us at the moment. So UTC uses normal grayscale ultrasound. It uses a computer algorithm, having taken 600 serial slices along a tendon, using a, where have I got it? I haven't got a picture. Up here, the probe here. So it moves in a motorised unit, 600 slices at 0.2 of a millimetre, compiles them, and what we can then do is start to look at the differences in collagen structure via the different colours. Now, it was initially validated in equine tendons. It was a vet that developed this, and it was validated in horse data, essentially. We've just done a study using one of our intercalated students on human tissue at Leicester, and we've basically shown that this particular colour that we get seems to correspond to collagen type 3 and type 5 and not type 1, whereas type 1 seems to be related to the other aspects in cadaveric tissue at the moment. So it seems to look like it's validated in human tissue as well, because that's important to do because it's not been done. But there's some issues with it, and it's a small study still. But it looks good. Now, clinically, what you do is then you draw around the tendon, run the computer algorithm, and it'll give you a nice pretty picture of the tendon and tell you how much is what. Now, this is better because unlike the B mode, I can quantify it. I can make sure I've done the exact same bit from the calcaneum, the last slide with the calcaneum visible. I can count up, it's painstaking, takes a lot of time. We can make sure that we quantify the exact same size. It's 1 centimetre, 50 mil, 5 centimetres of the tendon, whatever we deem we want to look at. And we can work out the percentage of red, so that type of structure, percentage of black, which you won't see on that, but it'll come up with it when you quantify it, which is cellular tissue and amorphous sort of fluid. Or we can look at the collagen components. So we can actually start to look at it in a bit more detail. Now, the first study that was done on UTC doesn't tell us how they did any of this. And that's the methodological flaw we have with it. So in that systematic review saying that structure doesn't correspond to pain, it has issues because certainly the UTC one wasn't well defined with how they did it. So it's not repeatable, and it gives us all little further images here. Now, the reason I like that is because that can tell me how much of the Achilles is made up of aligned tissue, so the blue and the green colour, good, healthy, thick bits, so nice fascicles, versus these smaller fascicles within the tissue, the type 3 echo, the red or the black. And Sean Dockin and Jill Cook have done that, and what they've suggested in tendons is that anyone with tendinopathic tendon has plenty of healthy tissue, and the diseased tissue doesn't really matter because the tendon responds and gets much bigger. Okay? Donut in the hole is the theory, which we'll go into in a second. We recreated the study because we didn't like how they looked at the tendon, because what they did is they looked at the whole tendon, 1 centimetre to 6 centimetres from insertion. Well, I only care about the disease portion. I don't care about the rest. So we standardised 1 centimetre around the worst slide. So literally find the worst bit of the tendon, the most tendinopathic section, and quantify it around that. And what we identified is a group of around 20%, 21% of individuals that have less than the lower interquartile range for healthy people. So less healthy tissue than maybe they should have in their Achilles. And we think they're potentially a high risk for going on to rupture. Okay? So we can look at aligned content, which may be more important. And we can measure that, and we can start to identify what goes on. So we have tendons that can look like this and this. This diseased tendon has a big portion of disorganized tissue, but it also has lots and lots of healthy tissue around it. It's responded by getting bigger. Now this disease one has responded by getting bigger, but is full of quite disorganized tissue. That structure will be much more mechanically weak. If you were to cut them out, if we could ever get ethics to do that on a human, chop it out and actually stick it in some of Hazel's strain gauges, we're going to see a total different entity. And we know that from horse data and a whole variety of other tendon studies that have been done in the past. That will snap much faster. It doesn't have the healthy collagen to actually help transfer some of the load across. We also know that when we've done that study, we can distinguish the symptomatics from the healthy. So symptomatics are red, healthy people are in green. So the amount of aligned structure is pretty similar across both groups, but the amount of disorganized tissue is massively different across groups. Okay. Now, this is better because when we do the grayscale, we can see a diseased area, a hyperechoic area, but we can't see whether it's got good tissue in or not. That doesn't show up on grayscale. This allows us to identify whether there is healthy tissue within that area or not. It's much more accurate at doing that. Okay. What we also can do with this sort of technique is we can look at the response to training loads. So there's Aussie data from Australian rules footy and horse racing, where they've been able to show a transient response in the tendon with basically an increase in this type of echo pattern. So normally there's sort of a substantial component of green fibre, and it goes more towards this blue fibre, suggesting there's a little bit of increased fluid or the sort of the intervesicular sort of fluid that we'll see in the tendon, and you actually get a bit more of a wave in the collagen bundles when we do the scan. And that's been shown in a variety of studies already, and we've recreated it in rugby union over here and shown exactly the same thing. And it seems to peak at 2 days. It's been done with normal grayscale ultrasound as well in the past. So it looks like a promising sort of confirmation of what we find. And it matches some of the previous data by Magnussen's group, suggesting you get collagen synthesis, collagen degradation, net effect at 2 days, and that's when you see a biggest change on this, is around the 2-day marker, and then it seems to return to normal after that period. So it seems to be measuring a transient change in tendon as a response to load. And that may be important because what we've shown in our group is that the people with tendinopathy don't have that response. So their tendon doesn't respond to the load. The healthy people's does, it changes. The disease group don't. And we think, again, we might be able to use that as an early indicator of high-risk individuals going forward, because that, at the end of the day, is the holy grail. Let's look at actually predicting what's going on. Now, the Jill's group and Sean Dockin have identified the donut and the hole. So the hole is the disease area, the donut is the healthy tissue, and they think that the tendon tends to respond by the healthy tissue getting bigger. That doesn't happen in all individuals, I don't think. And that's the problem when you look at outcome studies. If you measure the AP diameter of the tendon, we'd expect it to get narrower as you recover, return to normal tissue. Well, some probably won't. Some will probably grow and get bigger and get more tissue, generally speaking, to compensate. Some people, maybe the younger ones, will actually shrink and go back to size. But when you look at a mean response to clinical care, if some have gone up and some have gone down, the mean stays the same. So you don't see any benefit. We maybe need to be a bit smarter with what we're anticipating to see as our change, and think about the clinical alteration in structure as well as we go forward. We also know that structure, just go put this out. Their sort of theory at the moment is that structure can't change. The diseased area, this bit, cannot recover and can never reverse back to normal tissue. Okay. We know in healthy people that the tendon can adapt, and it adapts by normally increasing its cross-sectional area. What we know in diseased tendons, particularly after plantaris stripping, so this is studied by Lorenzo Maschi at Pure Sports and Hakan Alfredson, is that the diseased area visualised on the UTC here gets better as we go on, and that corresponds to the clinical improvements. So we know that actually the tendinopathic lesion can improve. That's not intratendon surgery, that's extra-tendon surgery, just the stripping at the front of the tendon, similar to the high-volume injections that Opto uses. So that looks like we might be able to see changes going forward using these type of methods. Hazel covered the sort of elastography a little bit earlier, and I'm not going into it, thankfully, and the spectral tracking devices are available. that's where a lot of the novel imaging is going at the moment, certainly from a research perspective, but it hasn't extrapolated into clinical care at the moment because we still don't know what it's telling us exactly. So once Hazel's done all the new stuff and developed your lovely new imaging method, which I really look forward to, then we might be able to use another clinical tool to look at this. But there's a lot of interesting data suggesting a correlation between elastography and function matching with your symptoms, basically. So that seems to be probably the more promising bit than purely on the structure alone. UTC are developing an elastography probe that will use supersonic shear wave and combine the two images as well. So there's certainly a shift towards a tool that will do two of these things, I think, and it sounds like that's probably where you're going as well, is structure and the sort of mechanical components of the tendon need to be measured in unison. Okay. So at the moment, we think we can probably use it to look at sort of athletic monitoring and look at transient changes in the tendon after strain and loading. And we think, identify some high-risk individuals. And that's where our research will be going in the future, is to look at whether we can identify these people first and then do an intervention study to see whether we can reduce the frequency of actual getting tendinopathy, primarily in the Achilles, as I said. So the big messages from today really are, ultrasound, as we know it, is great for diagnosis. We need to think more about the diagnosis as well and split up into those subcategories we had up earlier. And we probably need to come up with different treatments for those different subcategories of tendinopathy. Structure and symptoms alone, we're never ever going to match. The example I give to my patients, I trap my thumbnail in a door. I get a black thumbnail, the two match up. My pain and my structure match on the day 1, day 2. 3 months later, still not growing out, still got a black, dodgy looking nail, my image looks dodgy, I don't have any pain. So why would I expect any other part of my body to be any different to my thumb? I wouldn't, and I know that sounds weird to give it as that explanation, but it just maps through. So B mode's good, get cracking with it. Attend Chris's session later, so Chris Myers looking at ultrasound imaging, because it has a critical role to play in our interventions and where we're going with our clinical care, but we need to do better and come up with different interventions to match the different disorders that we can subcategorise to. There may be places for some elite sports, but that's not who most of us deal with day in, day out. So we need to sort of map it. My key, I think, is really to make sure we individualise everything. We look at what that person has and we try and titrate the treatment to that disorder and ensure that we actually then re-image the right thing going forwards and use the right tool for that imaging. There is not going to be one best tool. It's going to be a variety of tools just like there is now. And I think that's what will go forwards in the future. So basically, think a little bit more when you're doing your imaging. Thank you for your time. Sorry if
Okay, good morning everybody. First of all, thanks Simon for inviting me to present my data here for the first time. And I'm really honored to share a stage with such big researchers today. I'm presenting the findings of a case control study we've done assessing kinetic chain strength and psychosocial aspects in adult runners with Achilles tendinopathy. So our overall question was, what's the relationship between kinetic chain strength, psychosocial aspects, and Achilles tendinopathy? Our initial hypotheses were that runners with AT may have altered strength levels relevant to kinetic change movements and also negative pain beliefs. So this could be this is a diagram where we did like with a possible association between these three aspects. So the kinetic change strength could be associated to the presence of AT, and psychosocial aspect could be effect modifiers of this association. So there's a lot of confounders that could affect this relationship. There's a couple of them that we took into account on the left side, and there's some other ones that we couldn't control, like antibiotic use or systemic disease, or if subjects had high cholesterol and diabetes, for example. So I had never been to Australia before, and I thought that, mate, your supervisor is Australian, and there's a big running population there. So maybe that's a good opportunity to go there. So I flew to Melbourne last year and to do this data collection there. And what we looked for was basically men who run, adult men, moderately active, and with a minimum running activity per week. Inclusion criteria for the Achilles tendon group was mid-portion Achilles tendinopathy, and we looked for symptomatic runners. So runners that could be able to hop, to do 10 single leg hops, and with pain in hopping. This had to be confirmed with ultrasound diagnosis. So exclusion criteria was any medical condition precluding ability to participate in physical activity, insertional Achilles tendinopathy, previous Achilles tendon rupture or surgery, and any injection in the tendon or any other injury affecting the study. For control group, previous Achilles tendon pain or asymptomatic pathology was also a reason to exclude participants in the study. Okay, so what we had, we recruited 17 runners with Achilles tendinopathy, and we matched controls purposefully in age and activity. So we had 31 subjects in the study. And what did we do? What we did was, first of all, we asked them to fill up some questionnaires. They are they are validated questionnaires. Two of them are focused on Achilles tendon, which are Visa A and Achilles tendon belief questionnaire. And the other two were more general, was Tampa scale of kinesiophobia and PAS 20, which is a short version of pain anxiety symptoms scale. Once they had completed the test, the questionnaire, we asked them to do some physical tests, which were some strength testing and some ankle dorsiflexion test. We didn't have any isokinetic device, so we tried to do with gym equipment. So we for the triceps uri we did some standing calf raises endurance test, and then once in the gym we measured seated calf raises, leg extension, and leg curl with a 6RM calculation, and we also did some hip muscles dynamometry following Christian Thorborg's protocol, and we did some ankle dorsiflexion measurements with inclinometer. Here are some of the testings we did. Like, for example, for seated calf raises, we used the Smith machine and with 80 degrees of knee flexion, and the standard calf raises, and what most of you will know this test. Okay, so the results. What we found is that participant characteristics and questionnaires, we found that the AT group was slightly heavier, so this was a significant finding, and the Visa A, as we could expect, was also different, lower values in the Achilles tendon group. And here the interesting finding is that Achilles tendon belief questionnaire was higher in the Achilles tendon group compared to controls. So both of the questionnaires that were specific to tendon, to Achilles tendon, were significantly different, whereas no changes were found for kinesiophobia or Tampa scale of kinesiophobia or anxiety, PAS 20 questionnaires. We didn't find any changes, any differences for age, height, or physical activity neither. Okay, when we matched the groups, we found standing calf raises, seated calf raises, and leg extension were significantly different between the affected side of Achilles tendon group, or the most affected side, and the right side of controls. And also in the other, when we compared the unaffected side or the less affected side of the AT group with controls, we found seated calf raises was significantly lower. So these results confirm Seth's findings about weakness, bilateral weakness in seated calf raises. After that, what we did was we compared within legs in Achilles tendon group, and we found standing calf raises and seated calf raises were decreased, were weaker in the affected side or the worse side of both legs. And we suspect this could be due to pain. Okay? So here in this table are all the findings that we found significantly different between groups. And what we did is we input them in a stepwise logistic regression to see how they were associated with Achilles tendinopathy. But what we did, we excluded visa A, as it's obvious that we can see like that higher visa A it's correlated with Achilles tendinopathy. So we excluded visa A and we excluded unaffected seated calf raises because we were interested in the affected side. And what we found is that higher Achilles tendon oblique questionnaire and lower seated calf raises were the most associated with Achilles tendinopathy. So if we go back to the diagram, we could see that seated calf raises and the presence of AT are strongly affected, and that Achilles tendon oblique questionnaire might be affecting this relationship as well. Unfortunately, our sample size was not big enough to state which confounders were important. So the limitations of this study are the small numbers we had, that 7 of 17 participants in the Achilles tendon group had bilateral symptoms. We are not happy with the IPAC questionnaire to quantify activity level, so that was Dylan's decision, and he's not happy at all with that. And pain and fatigue might have influenced these outcomes because we were doing other tests for other studies in the same day. And testing wasn't blind because I did all the testing. So, okay, so the conclusions are that runners with symptomatic AT have impaired strength levels of the triceps surae, but particularly an Achilles tendon pain-related negative beliefs. That there is moderate strong evidence that seated calf raises and Achilles tendon belief questionnaire are associated with AT, and that soleus muscle seems to be the most affected muscle, and the changes might be bilateral. So the clinical application for this is that clinicians should consider targeting triceps surae strength. Like this is as a detail, subjects in the control group were coping with 1.3, 1.4 their body weight in the 6RM in a 6RM test. Education about pathology and clear guidelines in load management may be indicated even in subjects with AT that run. Okay? And other major muscles of the kinetic change may also be worth considering, as each person may adopt different strategies. I would like to thank you to everybody involved in this study. Especially, I would like to thank Peter and Dylan. And if you have the chance to do some research in Australia, I highly recommend it. Thank you very much. Thank you.